Hi, everyone. It is February, and this is the Heart Rhythm O2 podcast. I'm Jeanne E Poole, the editor-in-chief. We start out today with a group of 4 papers focused on atrial fibrillation representing patients in Asia. The first paper is titled Phenotypes of Atrial Fibrillation in a Taiwanese Longitudinal Cohort, Insights from an Asian Perspective, by author Yung-Chi Xu. As a background, the authors note that patients with AF represent broad and heterogeneous medical phenotypes, and importantly, that the Asian population is poorly characterized. The objective of this study was to identify distinct phenotypic clusters of patients with AF and evaluate their associated risks of ischemic stroke, heart failure hospitalization, cardiovascular mortality, and all-cause mortality. The patient population included 5,002 adult patients with AF from the National Taiwan University Hospital between 2014 and 2019. To identify these patients, the author used an unsupervised hierarchical cluster analysis based on the CHADS-2 VASC score. The primary results of this study is that 4 distinct groups of patients with AF were identified. Cluster 1 included diabetic patients with HFpEF and CKD. Cluster 2 included older patients with low BMI and pulmonary hypertension. Cluster 3 patients were those with metabolic syndrome and atherosclerotic cardiovascular disease. And Cluster 4 patients were those with left heart dysfunction, including reduced ejection fraction. For the outcomes of the combination of TIA and ischemic stroke, cardiovascular mortality, incidence of heart failure hospitalization, and overall mortality, the second cluster, which was the older patient with low BMI and pulmonary hypertension, had the highest risk in all 4 outcome categories. The next highest group were those with HFpEF combined with CKD. The risk of the top 3 risk groups, which were clusters 1, 2, and 3, were individually compared to the lowest risk cluster 4 group to determine the magnitude of the risk. Cluster 1 compared to Cluster 4 had a hazard ratio of 1.87. Cluster 2 to Cluster 4 had a hazard ratio of 2.06. Cluster 3 compared to Cluster 4 had a hazard ratio of 1.7. The author's key findings include, first, that the study identified 4 phenotypic clusters of patients with atrial fibrillation. 2, significant differences in ischemic stroke were observed across the clusters. Cluster 2, which again were the ones with low BMI, pulmonary hypertension, and older age group, had the highest rates of ischemic stroke, heart failure hospitalization, cardiovascular mortality, and ACM, with approximately twice the stroke risk and 3 times the mortality rates compared to the other clusters. Also, in this high-risk group, 23.5% of patients did not comply with anticoagulant treatment guidelines. The authors concluded that a data-driven algorithm can identify distinct clusters with unique phenotypes and varying risks of cardiovascular outcomes in patients with AF, enhancing risk stratification beyond the CHADS-2 VASC score. The next paper is an editorial commentary for this paper. The title is Machine Learning to Identify Phenotypic Clusters of Patients with Atrial Fibrillation by Drs. Hani Essa and colleagues. This editorial discusses improved methods to identify and characterize patients with AF and characterizes the approach to AF when considering patient genetics, ECG characteristics, echo characteristics, type of AF, EMR data such as past medical history, CHADS-2 VASC score, and then using artificial intelligence to help determine the decision for oral anticoagulation. The next paper is titled Electrical Isolation of the Left Atrial Appendage in East Asian Patients with Atrial Fibrillation by Dr. Jin-Soon Park. The background of this study is the recognition that the left atrial appendage is a source of non-pulmonary vein triggers in patients with AF, and that electrical isolation of the left atrial appendage has been shown to improve AF recurrence, but with an inherent risk of embolism without oral anticoagulation present. Little data, however, is available on East Asian patients, and that is the focus of this study. This is a single-center study of 41 patients in Korea who underwent electrical isolation of the left atrial appendage between 2009 and 2023. In 2 patients, electrical isolation was not successful. There was a repeat AF ablation procedure in 25 of the patients. The mean CHADS-2 VASC score was 2.8. The mean duration of AF was 5 years, and the mean left atrial dimension was 50.6 millimeters. The 1-year recurrence rate of atrial fibrillation, atrial tachycardia, or atrial flutter after electrical isolation of the left atrial appendage was 42%. This was in 21 patients during follow-up. The authors interpret this as effective given the duration of AF in this patient population, many of whom had already had at least one ablation. 6 patients, or 14.6%, went on to have a redo ablation, and 5 of these had durable isolation of the left atrial appendage. Amongst the 41 patients, 1 patient had cardiac tamponade, which was draining with pericardial centesis. All patients had lifelong anticoagulation. 3 of them had stroke or systemic embolism during the follow-up period. The authors concluded that electrical isolation of the left atrial appendage could be a safe and effective strategy for patients with long-standing AF with a history of failed ablations, especially with a high CHADS-2 VAS score. Lifelong anticoagulation, the authors posit, is mandatory for patients undergoing electrical isolation of the left atrial appendage. The next paper is by first author Quan-Shin Liu. The title is Association Between Dementia and Left Atrial Appendage Occlusion in Patients with Atrial Fibrillation, a TRI-NET-X-based retrospective cohort study with target trial emulation. The authors note as way of background that AF is a common cardiac arrhythmia linked to an elevated risk of stroke and dementia, and that left atrial appendage occlusion might reduce the risk of dementia. In this study, the authors compared the effectiveness of left atrial appendage occluder devices versus direct oral anticoagulants in reducing the risk of dementia in patients with AF. The authors mined the data from the TRI-NET-X research network to identify patients with AF. They were allocated into 2 cohorts, 2,270 patients in each cohort. Patients were treated either with left atrial appendage occlusion or with the DOAC, and they were analyzed using propensity score matching. The primary endpoints were 1, composite of dementia, vascular dementia, and Alzheimer's disease. Secondary endpoints included mortality, ischemic stroke, intracranial hemorrhage, and major adverse cardiovascular events. Follow-up was conducted over 3 years. The authors found that at 3 years of follow-up, the risk of the composite of dementia was lower in the left atrial appendage occlusion group than in the DOAC group, with a hazard ratio of 0.57. In subgroup analysis, the left atrial appendage occluder group consistently displayed trends of a reduced risk of the composite of dementia compared with the DOAC group, irrespective of age greater than 80 years. Also, it was irrespective of sex, types of AF, and types of DOACs. The author's key findings are 1, that patients with AF who underwent left atrial appendage occlusion had a significantly lower risk of developing the composite of dementia, undifferentiated, vascular dementia, and Alzheimer's disease outcome compared to patients on a DOAC with a hazard ratio of 0.57. Second, when looking just at the vascular dementia or Alzheimer's disease, the left atrial appendage occluder device showed a trend toward reducing the risk. Third, the protective effect of left atrial appendage occlusion in reducing dementia risk was consistent across various subgroups, including age, sex, types of AF, and specific types of DOACs. The authors note the need for further studies with larger cohorts and extended follow-up. The fourth paper in this group, looking at patients with AF in Asia, comes from Japan. The title is Impact of Atrial Functional Substrate in Patients with Atrial Fibrillation, the Potential Utility of Decremental Evoked Potential Mapping in the Atrium, by Dr. Yasuhito Kutaki. The authors note as background that decremental evoked potentials, or DEEP, DEEP, is one of the functional substrates used to identify critical targets of reentrant ventricular tachycardia. And in this study, they proposed to use DEEP during atrial fibrillation to identify the functional substrates and clarify their clinical significance. The patient population were those coming for AF ablation between April 2023 to March 2024 at Totori University Hospital. All patients received cryoballoon pulmonary vein isolation and then evaluated DEEP at the left atrial roof and posterior wall using extra stimulus pacing maneuvers. Next, the relationship between atrial DEEP and clinical variables, including the pericardial fat volume and other clinical outcomes, was performed. A total of 102 patients were included, of whom 45% had persistent AF. 53% of the patients exhibited DEEP properties. The authors find that DEEP was more prevalent in patients with persistent AF, 61% versus 39%, and also in those with higher brain natriuretic peptide levels, or BNP. And finally, also a greater pericardial fat volume. In addition, the authors find that patients with atrial DEEP had more early AF recurrence after ablation procedure. The authors conclude that this study demonstrated a correlation between atrial deep and longer duration of AF, higher BNP levels, greater pericardial fat volume, and more early AF recurrence, suggesting that deep reflects a certain aspect of atrial electrophysiologic modeling and is a potential ablation target for AF. Now, switching to other topics, the first paper comes to us from Indonesia. The title of the paper is Stylet-Driven Leads versus Luminless Pacing Leads in Patients with Left Bundle Branch Area Pacing, a systematic review and meta-analysis by Dr. Gilkey Karwicki. The background is that the authors note for this paper, despite advancements in lead designs for optimum left bundle branch area pacing, limited data exist on the performance of stylet-driven leads. They then go on to perform a meta-analysis to address this question and compare the performance and safety of stylet-driven leads compared to luminless leads. The authors performed a systematic literature search using PubMed, Europe PMC, and ScienceDirect for studies that compare the outcomes of stylet-driven leads during left bundle branch area pacing compared with luminless leads. Study outcome measures included peri-procedural parameters, pacing metrics, and complications. A total of 6 studies involving 3,991 participants were included. Left bundle branch area pacing procedural success was compared between the two approaches. The success was 90.2% for stylet-driven leads and 90.5% for luminless leads. Compared with luminless leads, the stylet-driven leads appeared to result in a shortened procedural time by almost 12 minutes and shortened fluoroscopy time by almost 3 minutes. Also, they found that stylet-driven leads had increased capture thresholds and reduced lead impedance at implantation, although during follow-up there was no significant difference between the two types of leads on these measurements. Additional comparative data included observation that the number of lead implantation attempts was similar between stylet-driven leads and luminless leads, 2.6 versus 2.3. However, lead dislodgement and lead-related complications occurred mostly in the stylet-driven lead group, and there was no difference in septal perforation or life-threatening complications. The author's key findings are: 1. Stylet-driven leads positioned in the left bundle branch area demonstrated comparable results concerning successful left bundle branch area pacing rates and pacing parameter stability during implantation and follow-up. Second, stylet-driven leads were associated with higher lead-related adverse events, although rates of complications were rare in both groups. And finally, the potential advantage of one type over the other based on lead performance remains unknown, and the authors call for further additional long-term randomized trials. The next paper is a very important topic that we come across not infrequently. It deals with the question of women and their safety if they have implantable devices while pregnant. The title is Outcomes of Pregnancy-Related Hospitalizations in Women with Pacemakers and Defibrillators. The first author is Dr. Vaderman, Jeanne. The background is that there is limited information on pregnancy outcome in women who have previously undergone implantation of cardiac implantable electronic devices, or CIEDs. The objective was to describe outcomes of pregnancy-related hospitalizations in women with CIEDs. The authors used the National Inpatient Sample Database to identify pregnancy-related hospitalizations between 2016 and 2021. The authors identified 23,611,200 weighted pregnancy-related hospitalizations, of which 11,220, or 0.5%, had a history of CIED implantation. Of these, 5,105 had permanent pacemakers and 6,115 had an implantable cardiac defibrillator. The mortality rate during pregnancy-related hospitalization was significantly higher among women with ICDs at 0.9% compared to those without any CIED, which was 0.01%. There were no in-hospital deaths amongst pregnant women with permanent pacemakers. However, after adjusting for covariates, the excess mortality risk in women with ICDs was no longer noted. But pregnant women with ICDs remained at higher risk of cardiogenic shock with an odds ratio of 3.06 and need for mechanical circulatory support with an odds ratio of 2.37. The author's key findings are that first, amongst pregnancy-related hospitalizations, a history of pacemaker or ICD implantation was rare, occurring in about 0.05% of women. Second, in-hospital mortality was significantly higher amongst pregnant women with ICDs. However, after adjustment for covariates, the excess mortality risk was no longer observed. Third, even after adjustment for covariates, pregnant women with ICDs remained at increased risk of cardiogenic shock and need from mechanical circulatory support. And fourth, and finally, the outcomes for pregnant women with pacemakers are generally excellent and comparable to those of women without pacemakers or ICDs. The title of the next paper is Physical Activity Benchmarks for Implantable Loop Recorder Patients: The Role of ILRs in Cardiovascular Disease Management by Maeve Sargent and colleagues. This is a brief report paper that looks at the use of an ILR to assess physical activity trends from an accelerometer function. The authors used data from the Certitude registry and included 2,434 patients implanted with a Biotronic Biomonitor 2 or 3M ILR. The indications for the monitor were diverse, with about half for AF management and the others for syncope, cryptogenic stroke, unexplained falls, or symptoms suggestive of an arrhythmia. The author's key findings are that 1. Device-detected engagement in physical activity ranged from 2 hours and 14 minutes to 2 hours and 37 minutes across all diagnostic groups and years. 2. A significant declining trend in physical activity over the 3 years following ILR implantation was identified across all groups with a p-value of less than 0.0001. 3. The study suggests that ILRs can be effectively utilized beyond traditional diagnostic roles to enhance disease management through activity monitoring. And finally, establishment of general and group-specific physical activity norms, coupled with the observed declining trend in physical activity post-ILR implantation, highlights the need for better disease management strategies. The next paper addresses an interesting question, which is whether asthma therapy with beta-2 agonists are a risk for patients with long QT syndrome. The title is Asthma and the Risk of Cardiac Events Among Patients with Long QT Syndrome After Age 40, first author Alan Barshashit. Using the Rochester Long QTS registry, the authors identified patients over 40 years of age who had a history of asthma and treatment with a beta-2 agonist inhaler, and looked for an association with cardiac events, which included syncope, aborted cardiac arrest, implantable cardioverter defibrillator shock, or sudden cardiac death. The authors found that amongst 1,020 LQTS patients, 162 or 16% had asthma by age 40 or over subsequent follow-up years. 63% of the 162 patients were treated with a beta-2 agonist inhaler. Patients with asthma versus no asthma had a higher cumulative rate of cardiac events from age 40 through age 75, 44% versus 26% with a significant p-value. A multivariate analysis showed that having asthma was associated with a twofold increased risk of cardiac events. Further, on subgroup analysis, the authors showed that the association of asthma with cardiac events was consistent within risk subsets of LQTS patients. These risk subsets included QTC duration, syncope prior to age 40 years, beta blocker inhaler use, sex, and LQTS genotype. All interaction p-values were non-significant. Next, asthma patients with LQTS who were treated with a beta-2 agonist inhaler did not show an increased risk compared with those who were not treated with a hazard ratio of 1.02. In summary, the author's key findings were: 1. Asthma was associated with a twofold increase in the risk of cardiac events amongst patients with long QT syndrome over 40 years of age, independent of other factors such as QTC duration, prior syncope, beta blocker use, sex, and LQTS genotype. Second, unlike in younger patients, the use of beta-2 agonist inhalers did not further increase the risk of cardiac events in asthma patients with LQTS, suggesting that the elevated risk is primarily associated with asthma itself rather than its treatment. Third, asthma patients were more frequently prescribed selective beta blockers, which are commonly used for asthma patients who need beta blockers but are known to be less effective in treating LQTS. These findings underscore the importance of careful management and monitoring for patients with both asthma and LQTS to ensure effective asthma control while minimizing the risk of cardiac complications related to QT interval prolongation. Next up is a paper titled Spontaneous Type 1 ECG and Arrhythmic Risk in Brugada Syndrome, a meta-analysis of adjusted time-to-event data by Dr. Sotirios Kiotis. The authors note as background that Brugada syndrome is associated with an increased risk of major arrhythmic events, particularly in patients with a spontaneous type 1 ECG pattern. The authors perform a meta-analysis on the prognostic role of spontaneous type 1 ECG in Brugada syndrome patients, combining adjusted and unadjusted data separately. A systematic search of PubMed and the Cochrane Central Register of Controlled Trials from inception to May 2024. Studies providing hazard ratios for major adverse events associated with a spontaneous type 1 ECG in Brugada syndrome patients were included. 18 studies comprising 7,238 patients were identified, with 10 of these providing adjusted and 17 providing unadjusted data. The authors then performed separate pooled analyses using a random effects model. This analysis demonstrated a significantly increased risk of major adverse events in Brugada syndrome patients with spontaneous type 1 ECG compared with those without, with a pooled adjusted hazard ratio of 2.05 and an unadjusted hazard ratio of 2.97. The authors went on to perform a subgroup analysis which showed higher risks in studies with non-Asian populations and those that included patients with no history of aborted cardiac arrest. In contrast, there was a persistent significant risk in studies accounting for syncope as a covariate. The author's key findings are first, that Brugada syndrome patients with a spontaneous type 1 ECG experience a significantly elevated risk of major arrhythmic events compared with those without this ECG pattern, with an adjusted hazard ratio of 2.05 and unadjusted hazard ratio of 2.97. Second, the risk of major adverse events associated with the spontaneous type 1 ECG is notably pronounced in the non-Asian population and in patients with no history of aborted cardiac arrest. The increased risk persists across various subgroups, including studies that account for syncope as a confounding factor with a similar elevated risk. And finally, the authors point out that this study only used studies with adjusted data, which they posit provides a more accurate measure of the actual risk, underlining the importance of multivariate analysis to accurately assess the prognostic value of spontaneous type 1 ECG. The title of the next paper is Epicardial Access for Ventricular Tachycardia and Premature Ventricular Complexes Ablation, an Institutional Experience, by Dr. Hema Srikanth Vemulapalli. The purpose of this study was to assess the outcomes, predictors of success, and complications associated with pericardial access during these procedures. This is a multi-center retrospective observational study of 265 patients who underwent epicardial access over 20 years between 2004 and 2024 from all Mayo Clinic sites. Of the 265 patients, 196 underwent VT ablation and the remaining 69 underwent PVC ablation. Amongst the 265 patients, 69% had at least one prior ventricular arrhythmia ablation, 19.2% had ischemic cardiomyopathy, 20% had structurally normal hearts, and 61.9% had non-ischemic cardiomyopathies. 3 further patients had mixed etiology of non-ischemic cardiomyopathy. The breakdown of the type of non-ischemic cardiomyopathy were dilated cardiomyopathy in 30%, ARVC in 13%, and cardiac sarcoid in about 6%. Acute success, defined as non-inducibility, was achieved in 61.7% of 162 patients tested. Partial success, that means the clinical arrhythmia was non-inducible, was achieved in 29%. 10% of the patients had recurrent VF prior to discharge, and another 10% had recurrent VT prior to discharge. Over 61 months of follow-up, 35.5% of the patients died, 13.3% underwent heart transplantation, and 31.6% required a repeat ablation for ventricular tachyarrhythmias. The event-free survival rates were 50% at 1 year. The authors conclude that successful VT ablation with epicardial access can be achieved in select cases, though event-free survival remains suboptimal. Advanced disease stage and persistent inducibility at the end of the procedure are predictors of poor outcomes. The topic of the next paper also is ventricular tachycardia ablation. The title is Clinical Outcomes After Ventricular Tachycardia Ablation with or Without Induction, by Dr. Benjamin Friedman and colleagues. This retrospective study addresses the topic of VT substrate mapping or mapping with VT induction, asking the question of the efficacy of VT ablation without VT induction. The patient population included 89 patients with an ICD having VT ablation between the years 2020 and 2023. The median age of the patients is 68 years, 89% male, 51% with infarct-related cardiomyopathy. The mean left ventricular ejection fraction was 38%. Patients with or without attempted VT induction were compared with respect to baseline characteristics and clinical outcomes using Cox and competing risks regression. Patients were followed for a median of 16 months after VT ablation. VT induction was attempted in 63% of patients. The one-year incidence of recurrent VT was 37% in the non-induction group and 58% in those who had VT induced. The subhazard ratio of 0.55. The one-year incidence of recurrent VT heart transplantation or death was 42% in the non-induction group and 62% in the induction groups with a hazard ratio of 0.58. The author's key findings are that 1, in a retrospective study of 89 patients with an implantable cardioverter defibrillator undergoing VT ablation, a strategy of avoiding VT induction versus attempting VT induction resulted in a similar incidence of VT recurrence, heart transplant, or death at 1 year. Second, both ablation strategies were associated with greater than 95% median reduction in VT burden over a 6-month period. Third, the authors note that their findings suggest that VT induction, recognized as a risk factor for hemodynamic compromise, may be avoided in some patients without sacrificing procedural efficacy. The next paper's title is Failing Hearts Are More Vulnerable to Dobutamine and Caffeine-Induced Ventricular Arrhythmias, Ameliorated with Dantrolene Treatment, by Dr. Lisa Greco and colleagues. The purpose of this basic research study was to investigate whether failing hearts had increased vulnerability to dobutamine and caffeine-induced ventricular arrhythmias, and whether dantrolene treatment provides therapeutic benefits in this condition. The authors used a myocardial infarction heart failure rat model with the experiment performed 2 months post-procedure. Sham surgery animals served as the control animals. MI heart failure rats were randomized to MI heart failure untreated and MI heart failure dantrolene treated groups. Dopamine, given at 25 milligrams per kilogram intraperitoneal, and caffeine, given at 50 milligrams per kilogram intraperitoneal, were administered acutely to induce the ventricular arrhythmias. The MI heart failure dantrolene group received dantrolene, 10 milligrams per kilogram intraperitoneal, 30 minutes before the arrhythmia test. Spontaneous CA21 sparks in isolated ventricular myocytes from control and MI heart failure rats were also examined. Researchers found that 1, dobutamine-induced less inotropic response in MI heart failure rats than in control rats. 2, dobutamine plus caffeine-induced ventricular arrhythmias in 9 of 10 MI heart failure rats, while it did not induce any ventricular arrhythmias in the control rats. Third, dantrolene treatment significantly decreased ventricular arrhythmia inducibility occurring in 2 of the 10 MI heart failure rats. Fourth, in isolated ventricular myocytes, CA21 sparks were significantly increased in MI heart failure rats, and dantrolene treatment decreased CA21 sparks in these animals. The authors conclude that although dobutamine evoked less inotropic effects, failing hearts were more vulnerable to dobutamine and caffeine-induced ventricular tachyarrhythmias. And second, that dantrolene treatment decreased CA21 sparks in isolated ventricular myocytes from failing hearts and ameliorated ventricular tachyarrhythmias induced by dobutamine and caffeine in MI heart failure rats in vivo. The next paper reviews how to set up an intravenous sotalol loading program. The title is Establishing an Intravenous Sotalol Loading Program by Dr. Couture del Grosso and colleagues. The paper describes how to do this as an inpatient program. They describe the protocol and correct monitoring. It's an important paper and can be referred to by institutions wanting to start up an IV sotalol program. The authors offer the following key points. First, rapid intravenous sotalol loading over 60 minutes for atrial arrhythmias achieves the maximum plasma concentration steady state under 24 hours in patients with creatinine clearance greater than 60 milliliters per minute, as compared to equal to or greater than 72 hours with oral sotalol loading, which causes a longer length of stay. Second, publications regarding IV sotalol's cost-effectiveness, efficacy, and safety are important to provide to the Pharmacy and Therapeutics Committee to receive formulary approval. And third, steps to develop an IV sotalol program include formulary approval, development of protocol, order set, and infusion process timeline, as well as pre-admission and discharge process strategies. The next paper is from our Global Voices section representing authors from Mumbai, India. The title of this study is A McGivering Way to Left Bundle Branch Area Pacing using the modified V1-V6 leads connected to the pacing system analyzer by Dr. Sanjay Patu and colleagues. The authors note the following background. They state there is a significant impediment to the availability of a fully capable electrophysiology procedure room and EP recording system due to healthcare cost restraints in resource-poor settings. The purpose of the study was to assess the feasibility and outcomes of using a conventional treadmill test machine, a 12-lead ECG system, and modified V1 and V6 leads connected to the pacing system analyzer to demonstrate conduction system captured during left bundle branch area pacing. The authors planned for LBB area pacing in 19 patients. It was attempted by a single operator using the Medtronic 3830 lumenless leads and the St. Jude Abbott stylet-driven leads in a mixed cohort of patients at hospitals lacking an EP recording system. Conduction system capture was assessed using modified V1 and V6 leads. The method was to connect the V1 lead of the PSA in the right fourth intercostal space to give a modified V1. The left arm electrode was placed below V6, and the AVL channel was used to record the modified V6 left ventricular activation time. Findings are that left bundle branch area pacing was successful in 18 of the 19 patients using the modified ECG recording method. 2. The modified leads act as a surrogate for V1 using a PSA to identify the paced right bundle branch block morphology. 3rd, the modified V6 was successful to measure the left ventricular activation time. The authors conclude that this pilot feasibility study identified that the modified V1 and V6 leads connected to the PSA are an alternative to an EP recording system to perform successful left bundle branch area pacing with excellent agreement and reliability of the values using the PSA with the 12-lead ECG. They note that this approach may be useful to other EP operators practicing in hospitals with health resource constraints and unavailability of EP recording systems. Now, to finish up this issue, there are a few letters to the editor that you can read, and this ends the February 2025 HRO2 issue and the podcast. Thank you, as always, for listening to this podcast, for your support for the Heart Rhythm Society's Open Access Journal. Have a great rest of your month, and we'll talk to you next month.